Good morning. Good morning. Such a pleasure to come back after 3 years. I love your country because I feel well here. So today we will have a very good day. Of course, we will learn about tissue management, healing, but we will learn all the new updates from the COVID. And you will see that the COVID gave us a very good opportunity to improve our knowledge and to make better job when we treat our patients. First of all, I want just to tell you who I am. I'm not a dentist. And this is why my wife is not happy. Because dentists, they do a lot of money. I'm a surgeon. I'm a general surgeon. I'm an anesthesiologist. I'm a biologist. And I'm a pain, therapist. But since 30 years, I do only pain management. Because this is the best specialty in medicine and the most difficult specialty in medicine. And today we will share a lot of experience in surgery and around the surgery. When we do a surgery, what do we expect? We expect to improve the wound healing of our patient. We expect to improve the osseointegration. But the objective, because my friends, you never forget that we're treating humans. And we need to give them a treatment for the life, not only for a few years. This is the objective, is to achieve a long-term stability. And in brief, we need to get predictable and reproducible treatment. When we do a treatment, we must know what will happen after. Not to say, oh God, please help me. Okay? And this is the objective of it. We heal naturally because it's physiologic. Because wound healing is natural. But who organized it? Who is responsible of the healing? Only the blood. Always the blood. The blood is the main responsible of the wound healing organization. Blood supply. We talk all the time about the blood supply, but this blood supply has three functions. The first is to bring food to the tissues. Oxygen, proteins, glucose, etc. The second function of the blood supply is to bring all the healing elements. Platelets, white cells, mesenchymal stem cells. But the blood has another role, which is so important. The blood clots. And we say in biology that the blood is an active biomaterial. What does it mean? Active biomaterial. If we mix the blood with a bone blood, just mixing the blood, what happens? This is what we published in 2015. When we mix the blood with the material, we see how the implant bed vascularization increases early and later. And this is why we say active. Because the blood clots, and the clot is one of the main responsible of the new angiogenesis. What do we have? We have all the cells. Red cells, white cells, platelets, stem cells. What is the function of the platelets and the white cells? Is to release growth factors. But what is a growth factor? When I want to ask my daughter something, I say, "Hey, Elisa, do this." And she obeys. But when a cell wants to give an order to another cell, they don't have sound. They don't have ear. The message is done by a protein. You send the protein, and the protein will give the message. Do this, do that, stop. And these proteins are growth factors. And this is why we name them cytokines, because they push the cells to move. These growth factors are so important because they organize the whole communication between the cells into the body. First, the platelets. They are rich in granules. We name them alpha granules. And these granules, when the blood clots, the platelets then release the growth factors. All these growth factors. We need the clotting. And this is what we have as evidence. The platelets, they release the growth factors only after clotting. We need the clot. The white cells, they do the same. They release growth factors. But these growth factors are mainly androgenic. And we will see later how these proteins released by the white cells are inducing inflammation. And we know that inflammation is the beginning of the recovery. What is the function of the growth factors? The function is to induce growth. The function is to induce differentiation. New vessels grow. And this is why these factors, they play a predominant role in wound healing. We heal because we have the growth factors. We have so many factors in the biology. Almost 150 growth factors. A lot. But why so many factors? Because we have so many things to do. Every day, day and night, the whole life. We survive because we have the growth factors. But for us, clinicians, what is important is to identify that the growth factors, they induce angiogenesis, they induce chemotaxis. We want to send the cell in a site. Okay. We send the factor will say, hey, go to this place and do the job. But what is the main message? Each factor has a specific. Okay. Let's take one example. We do extraction. And what do we see? We see that the socket is closing. The gum is coming to close the socket. It's not by chance. We close the socket because we have in our body one factor which organizes the socket closure. It's the KGF, keratinized growth factor. This is why we close the gum. But we can ask a question. And if by chance we miss this factor? If we don't have this factor, the closure is delayed or impossible. No KGF, no closure. This is the situation that we can meet in patients taking bisphosphonates. When they take bisphosphonates, they have a risk of osteonecrosis. But why do they do an osteonecrosis? They do osteonecrosis because they don't close the socket. Because KGF is missing, and then the bone stays exposed to the infection, to the saliva, during many weeks or months, and this is how start osteoporosis. If you go to the literature, what will you see? You will see that 80 to 90% of osteonecrosis occurs after extraction. You understand why? Because they don't close. I will show you clinical cases about this issue. 1998 was the year where we started to use centrifugation of blood in order to increase the amount of platelets. Because we wanted to increase the amount of growth factors. But the beginning of the PRP was by using anticoagulants. Because they started to use the blood from blood banks. We need to put anticoagulant if we want to avoid the coagulation, the clotting. But again, what is the physiology? The physiology is that we need to organize the clotting if we want to organize it. This clot is the beginning of the wound healing because we have the factors released by the platelets and the white cells, the clots. And then, from my side, it was logic to say, if we want to help the healing, we need to use a clot. But if we want to use a clot, we need to remove the anticoagulant. And this is the concept of PRF. The concept of PRF is just that we do a centrifugation of the blood without anticoagulant. And then we collect the blood without anticoagulant. And then we spin it. And what happens after the spin? We have a clot. PRF is a clot. Fibrin clot. So, we have platelets, we have white cells, and we have the fibrin. And you see that the name is PRF, the F. Why I was so, how to say, focused on the F? Because fibrin is very important. Fibrin will give us the clot that we remove from the tube. We remove the red cells and then we place the clot into the box. You see? We remove the red cells, we scratch the red cells, and we place the clot into the box. And then we use the tray in order to produce the membrane. This is the second step of the PRF. You see? We have now a membrane. What is the scientific evidence today? Today, we have still a lot of interest because we see that the amount of publication is growing, still growing after 22 years. It means that the product maybe has some function. We have enough evidence today about PRF. But I told you, I gave the name PRF because the fibrin is from me, probably the most important part of the product. What is the definition of the fibrin? Fibrin is a temporary extracellular matrix. Fibrin is a reservoir of growth factors. And fibrin is the place where the new vessel starts. We say fibrin is a temporary matrix. What does it mean? A matrix is getting cells in order to produce a new tissue. And then it will help us. And you will see that today we will develop a new technology, open wound. In dentistry, we know that we work into the mouth and we need to close the sound in order to avoid infection. But today, we are moving to a new concept of surgery, leaving the site open, because sometimes it's difficult to close. We will talk the whole day on the open. But I want to show you what is a temporary matrix. In this case, the surgeon made implants, but you see that the vestibule is short, and we need to make a vestibuloplasty. Incision, split incision in order to separate the flap and then to fix the flap to the periosteum. You see? This is the concept. And then we have a huge site without gum. How to make a new gum? We can go to harvest the palate and put this tissue to obtain a new gingiva. But we can use a matrix that we have in our body. And what is this matrix? The fibrin. We can use the fibrin, and obviously we need to fix it. And this fibrin will give us in 1 week a new soft tissue. This is the function of the fibrin, is to be first a matrix. When we want, but this matrix will also be keratinized. When you miss a soft tissue, you can use the fibrin and it will give you a new gum. Sometimes we do extraction and implant, but closure is difficult. And I told you, now we are moving to open wound. What does it mean? If we cannot close, we will use the fibrin, because the fibrin will give us a new soft tissue. This is the function of the PRF. And look after 3 weeks. Look at the keratinized tissue. But fibrin is also a reservoir of growth factors. When the platelets, they release the factors. When the white cells, they release the factors. These factors are kept into the fibrin. And they are released slowly and continuously. The slow release is also a property of the fibrin. During at least 1 week, look, long-term release, continuous release. And this is what the biology likes. The biology doesn't like too much in one shot. The biology likes a little bit continuously. When you want to irrigate your garden, you organize a drop-by-drop irrigation. This is the nature. It's the same with the fibrin. So, the third function of the fibrin is to be the place where the new vessels form. We say new angiogenesis, but where does new vessels they appear? they appear into the fiber. This is the function. It's the fiber that the new vessels are inside, and this is why we will try to mix the fibrin with bone graft, because fibrin will help us to achieve a fast vascularization. So, just to show you how we started, it was by chance. A lady came to my clinic, pain clinic, and she showed me her leg. I told her, I'm sorry, I'm not a specialist of women. And she told me, I didn't come with my ulcers. I came because it's painful. Can you help? And then I said, my man, I need to find a solution. But what is our knowledge about pain? The main origin of the pain is the ischemia. When a tissue is missing blood, it sends you a message, pain. And then I said, if I want to help, I need just to increase the blood supply. How to increase the blood supply? At that time, we started to use PRP. But I said liquid is not good. Fibrin is the main responsible of the pain. And then I decided to take the blood, to spin the blood, in order to produce a clot, and we put the clot on the wound, covering the wound with a simple plastic forsyth. And after 2 applications, we can see that there is no still any infection. Why we are getting this wound healing? Because of, look at the vessels on the surface. The infection was gone because of the new vascularization. And this is after 1 month only. When we treat an issue after surgery, dehiscence and infection, the fibrin will help us to improve the vessels and then to achieve the wound. We heal because we have the vessels. It's not the direct action of the PRF. PRF induces new vessels, and vessels are responsible of the healing. Diabetic ulcer, the same. This young old lady was aggressed by a dog. This is how it happens after 1 month. Because if we can reorganize the new vascularization, we know that the vessels, they will do the job. But if we want to use PRF, we need a clot, but we need a good clot. And today we have the information about the condition. Condition related to the blood collection and condition related to the blood temperature. Drawing must be fast. Why? Because we don't have anticoagulant. And then the time is limited. Because immediately when the blood is going out the vessel, start to clot. Then we have to run. The collection must be fast. Maximum is 15 seconds for a tube. And we go to make an immediate certification. Immediately. In order to not lose time. But if the collection is slow, then we will meet the clotting into the tube. And we know that if you clot, you use the fibrinogen to make the clot. It means that at the end, you will have less fibrogen, and means small clot. This is the main condition, the main cause of failure. Because if you lose time, you will get a smaller clot, or no clot at all. You see, this is a fast collection. Look at the clot, and this is a slow collection in the same patient. Look how the clot is poor, and obviously you have a smaller clot. Good. At the beginning, we started to use centrifuge of 8 tubes, but now we use centrifuge of 12 because we have the evidence. As the fibrin is a matrix, as we need to increase the amount of matrix. And then we moved to a centrifuge of 12, but you can understand, if we want to collect 12 tubes, at the end of the collection, the first are clogged. Too much time, 3 minutes. We need to find a solution to reduce this time. How to reduce? It's very simple. If the collection is more than 6 tubes, more than 6, then we will split the collection. For example, in this case, I want to take 8 tubes. Okay, I start with the 4 tubes, and then I launch them, saving time. Okay? And during this spin, then I continue to collect it. And when we finish the collection of the last 4 tubes, we stop the spin in order to put the following tubes. And then I can restart the centrifuge. You will say, but the last tubes, they will be spun at 14 minutes, but the first at 15. It's not an issue. There is a minimum, but there is not a maximum. Even if you spin more, 16, 17, doesn't matter. The job is done. So, all the time, when you want to collect more than six, please split the collection. 4 and 4. And like this, you reduce the time between the collection and the end of the spin. During 20 years, and even here in Vietnam, and mostly in Asia, we had some issues with the clothes. In Asia, even when I do myself the collection, I cannot achieve very big clothes. And during 20 years, I was asking myself, why? Why in Vietnam they have small clothes? And then came the COVID. And came the COVID, and I understood that the blood temperature is very important for the clot. What is the message? The message came from this small dog, Pom. We got Pom 1 hour before the lockdown. 1 hour. Small dog like this. And after a few days, Pom became sick. A lot of neurological symptoms. And I reminded that when I was a resident in neurosurgery, when we have a lot of neurological symptoms, we try to decrease the temperature. And this is what I do. And we save a pump just by reducing the temperature. And then in my mind I said, why we do not the same with the blood? Why we don't decrease the temperature of the blood, but how to decrease with this pump pack concept? If we want to reduce the temperature of the blood, we need to use cold tubes. When you fill the tube, immediately the temperature decreases. But how to get a cold tube? We store it into the fridge. But if we take out the tube from the fridge, immediately the temperature will increase at the room temperature. And this is what I did. I designed a cooler. And I gave the name to pump. Today, where is the place of the tube? In the fridge. Where is the place of the pump pack? In the fridge. But I designed another item, which is the popcorn. You remember I told you, when we want to collect more than 6, we split the collection. But we have another issue, is that after this A tube, the tubing of the butterfly starts to close. And then the flow decreases. And we know that when the flow decreases, we lose fiber. And then I said, I need to cold the tubing. And this is the concept of the pump coil. We put the pump coil with this gel pack. We put the pump coil around the tubing. And when the pump coil is good, look, pump is facing you. Means the pump coil is at the right position. And then we just fix it with a valve. Like this, the tubing will never clog. Like this, the blood flow will stay the same all the time. But now, we understand why in Vietnam, but in Asia, we had a lot of size clot issue. Because 30 degrees outside. But when the temperature is high, the blood is a bit higher. And then the blood clots faster. My friends, now, if you want to have a good life, you must stay into a fridge. Just to tell you that all the time, we can find an explanation of the issue. So, we take the tubes from the fridge and we put them into the pump pack in order to stay cold. And then we go to make the connection. We fill the tube and then the tube is coming back to the pump pack. We fill the tube and the tube comes back to the pump pack. Why? Reduce the temperature of the blood. And at the end, we go to put the tubes into the centrifuge. And we start. And look at the difference with, without, and with. We delay the clotting, we get more fiber at the end. Simple. Now, we can get big clots. We can even see the difference. We have at least 30% more fibrinogen because we just delayed the clotting. And then we saved a lot of fiber. We have the dual, when you see the panel, we have different settings. Because now we don't have only one PRF. We have several according to the indication. What do we want to do? And then we will go to select the position. When we open the power, the machine opens, the lid opens, and then I would like to tell you interesting information. Dentists are very good person, very smart, but they have one issue. They never read the manual. When they get the machine, immediately they want to test, and they don't read the manual. I want to tell you that there is a small hole on the right of the machine. What is the function of this hole? When you have a power failure, you can open the centrifuge with the forceps. This is what you miss when you don't read the manual. We have a rotor, and I wanted to make something simple to facilitate the tube position. Because we need to balance the tube, and then you have colors. It's easy to balance because just need to follow the colors. We need to balance because if we do not, we will meet shaking. Look at this. Blue and blue. This tube is wrong. And then if we start the spin with this position, we will meet a lot of shaking. And this shaking will damage the centrifuge. Take care. Then you stop, you organize again the good balance, and then you restart. We can meet vibration when we don't fill the tubes with the same amount of blood. You see? Why the blood is moving to the tube? Because the tube is moving backward. And then, as you have vacuum, as the blood is filling the tube. And it stops when there is no still any vacuum. But if you stop the collection before, then you will meet vibration, but light. You don't need to stop. We have a third origin today because we use red and green tubes. And these tubes, they don't have the same weight. And then we need to balance the green separately and the red separately. This is actually how we manage the centrifugation. At the end of the spin, what do we do? The first is to remove the tubes. But when we remove the tubes, we must remove the caps. You see, I take the tube and I remove the cap. I take the tube and look, I remove the cap and I put it into the holder. Remove the tube, remove the cap, put it into the holder. Remove the tube, remove the cap, put it into the holder. Why we remove the caps? Because we need to remove them. And then if you do it during this time, we save time. Okay? First, we remove the tubes from the machine. And secondly, we remove the cloth from the tubes. The place of the cloth is not to stay into the tube. When we finish the spin, we must remove the cloths from the tube. Why we must remove the tubes? Because after 3 minutes, after 30 minutes, and after 16. You understand that if you leave the cloth into the tube, the cloth shrinks, and then you will meet a very small cloth, which is not the objective of our centrifugation. Sometimes the plasma has not the right color. What is the color of the blood? The blood is red. Why the blood is red? Because we have the red cells. But the plasma is yellow. And this is why the clot is yellow. But sometimes the clot is not. The clot is white. And then we will say, why? We know why the clot is white. Because the patient took a meal, rich meal, before coming to the office. And when the patient is taking a rich meal, then the plasma has a milky aspect. The plasma contains a lot of chylomicrons, which are giving this white color to the plasma. There is not big change in the quality of PRF. Don't worry. How to use? If we want to use, we want to know what do we want to do. First, the clot, they go to the box. That's it. We take the clots and we put them into the box. And then the box will make a membrane. But we can make into the box plugs. Plugs for what? For socket. Because extraction is the main action of the dentist. And we can also use the liquid coming from the clots. This liquid will go to the bottom of the box and we name it the exudate. Exudate will be the key of the sticky. We make membranes and then we go to cover it. We can cut the membranes in small pieces. We can punch the membrane. First of all, when we do coverage, we cover the whole. We know that as we put more matrix, as we will get more tissue. And this is why we use a lot of them. This is the first destination. But we can also use a blade to make an incision into the membrane. On the gauze, but also in the box. Why do we have a slot here? Is to make the incision into the box directly. It allows the blade to move through the fibrin membrane. And then we can go to place this membrane punctured through abutments, through healing screws, and this is what we do when we do immediate loading. Why? Because we know that when we do immediate loading, we cannot close completely the site. The sealing is not perfect, and then the fibrin will help us to improve the sealing. We do an incision into the membrane and then we place the membrane through the abutment. Or we place the membrane through a healing screw. And this is how we can achieve the open wound technique. We can use also the PRF as a poncho through a healing screw in order to fill the gap. Which gap? The gap between the implant and the soft tissue. I will show you. We can cut the fiber. With the scissors, we can cut in order to mix this fibrin with the bone graft. This was the original technique. Because at that time we had only the fibrin to mix with the bone graft and after to use the liquid from the box, the exudate. we have in the box white cylinders, and there's white cylinders. We will use them with the piston to make a plug. We place the cloth into the cylinder, we push it with the scissors and the forceps. You see? And then we will go to use the piston to crush the cloth, to reduce the volume. But I want to introduce a modification of the process. In the past, we took the cloth in the box, and then we used the tray to press the cloth. In the past, we were taking the cloth into the cylinder, and then we were using the piston. But today, we use the pump pack. And what is the difference? The pump pack is introducing a delay of the cloth. It means that, I don't understand why sometimes, in the past, we were using the membrane immediately or crushing the cloth immediately. But pump pack introducing a delay in the cloth. And then, when we take the cloth from the tube, we don't press it immediately. We wait. Because the polymerization of the fibrinogen is not full. When we place the cloth into the cylinder, we don't crush it immediately. We wait a bit to have a better polymerization. But you understand that from the beginning to today, we have the time to get new science, to get new information, and to introduce some improvement. At the beginning, we were using centrifugation with a G-force, and then we imagine that the cells are pushed to the bottom. The force, the centrifugation force, will push everything to the bottom. And then I wanted in 2013 to make an histology of it, to see what are the cells into the cloth. And then when we did the histology of the cloth, we saw that all the cells are in the last millimeter of the last millimeter of the cloth. You find the cells. The whole cloth empty, nothing. And then for me it was easy to make a conclusion. The force is too high. The speed is too much. The speed is excessive. And this is why I started to introduce the low speed centrifugation constant. I said we need to reduce the speed in order to improve the cell's content into the cloth. The difference is that if we reduce the speed, we will increase the cells. Who produces the growth factors? The cells. If we want to enrich the cloth, we need to reduce the speed. The first speed of the PRF was 700 G, but I could not go less than 200 G force, because less than 200, the cloth is too small. Then there is no benefit. We can enrich, but we need to get to maintain the size of the cloth. But I decided to continue to decrease the speed through a liquid form. And this is how I introduced the PRF liquid by reducing the force and using another tube. Why to reduce the speed? In order to enrich in white cells, in platelets, but also in mesenchymal stem cells. Until 2013, we had a lot of issues to recover the stem cells from the blood because of the high speed. Then we can understand that the white cells, they produce angiogenic factors. And if we increase the white cells, we can increase the angiogenesis. White cells, they help the in vivo vascularization. White cells, they are the niche for the mesenchymal stem cells. Mesenchymal stem cells, they can work if they have the support of the white cells. And this is what we can see. What do we see? We see that high speed, medium, low. High speed, medium, low. Means that when we decrease the speed, we enrich the product. But if we are getting more cells, we will get more growth factors. It's very simple to understand, and it's very simple to follow the concept. And then I started to design different PRF. Different PRF for what? Different PRF because we have different indications. How are you? Okay? I see that you are tired. You know what to do? Right. Right. It will help you. So, but if we have different protocols, we need different tubes. And this is the concept. When we want to make a clot, we will use the red tubes. What are the red tubes? The red tubes are in glass. But people, they believe that they just need to take a glass tube, but not all the glass. We need a specific glass to achieve a good clot. And then to achieve a good clot size. We have a new protocol, which is the PRF liquid. We speed at the same speed, but only 5 minutes. This protocol is now used worldwide by all the plastic surgeons in order to make the sticky cartilage what they want to repair the nose and to make an aesthetic surgery on the nose. We can now make liquid, but we have different protocols. The two first protocols are for dental. Dental, we have two protocols, S-PRF and I-PRF. And we have one protocol for medical use, which is the I-PRF plus. Good. You follow me, huh? We have two protocols for dental. What is the S? The S protocol is the same that the red. You see, 1,314. What is the goal of this protocol is to make a liquid, and this liquid will help us to make the sticky. This is why the name of the program is S. But we can also use this liquid to inject it into the gum. Because when you use a clot, the clot is between the periosteum and the bone. But now we can put PRF inside the flap, inside the soft tissue. And I will show you some cases. When we want to make the sticky bone, we need both the red and the green. We harvest the green and we harvest the red. Because first, the green will give us a liquid. This is the S protocol pure. We can take with a needle or with a syringe. And then we go to place the liquid on the bone, right? Okay? But the liquid that you get with the S protocol will clot in 30, maybe 45 minutes. What we do? We take the exudate from the box and we put it on the liquid, on the S liquid. And then it clots in 1 minute. Maximum 2. And you understand that today we cannot make sticky bone without the exudate. And then we have a gel with the bone graft, and we can go to shape it. We can fold, but all the time we need to compact. We need to squeeze the sticky bone in order to reduce the size, the space between the granules. This is very important. Usually, dentists, they believe that they need to leave space for the vessels. Vessels are size is around 5 to 8 microns. You can squeeze. But when you squeeze the granules, you improve the osteoconduction. Space between the granules is too big. We need to reduce as much as possible. And this is why all the time we squeeze the sticky. And then we can go to use 1 piece. Today, we don't see any granule on the side because we stick the bone. It's so simple and so efficient. We save a lot of time. When we want to place a bone graft, we make 1 piece. That's it. After we cover with membranes. When we want to make a full maximum augmentation, we can use 1 piece of sticky. And you understand that we never see 1 granule. It's very clean. And we don't lose, because when you put the graft, you lose granules everywhere. Here, we don't lose any one. This is the concept of the sticky bone. We can design also, you see, we can place the membrane on the sticky bone already. And then we go to place the graft in one movement. We can design a sandwich. I will show you this at the end. You see, we can make a sandwich, means we have 2 layers of fibrin, and in between we have the bone graft. And we can cover with fibrin membrane. And look, when we go to the site, we use 1 piece. Simple. Okay. This is Paul. What is the behavior? She turns all the time when she's waiting the food. And then I said in my mind, why we do not the same with the sticky bone? Paul is my inspiration. And then I decided to design the palm swing. What is a palm swing? Palm swing is a jar, and this jar, blue, will help us to make the sticky ball. But now when we place the SPRF and the exudate, we just need to swing a little bit backwards and forwards. We turn exactly like ball, and look, we see that the sticky ball is coming very, very fast. We need only a few seconds to make a sticky ball express. And then we can go to place this sticky ball and to compact it on site. This sticky ball, produced with the swing, we compact it not on the table, but on the side, in the side. We can use the roll in order to flatten. Now we fix the thickness. When we want to make an apposition, we decide exactly which thickness we will use. Okay? We put the aspirate, we put the exudate, and then backwards and forwards. And you see the formation of the sticky ball is very, very, very fast. We can cut it, we can design exactly what we want. We can make some bands. And then we can go to decide exactly which thickness we want to use. Because today, we can fix exactly the thickness of the sticky ball. This is French cooking. Okay. If you want to make sticky ball, you need green and red. Okay? But if you want to increase the stiffness, if you want to make a very strong sticky ball, just increase the liquid, the S. Because S will give you fibrin, and fibrin is a sticky. You see? Very rigid sticky ball, you cannot follow it. Good. SPRF is for sticky, but we can make IPRF. What is IPRF? IPRF is for injection, but this protocol is not with 1,300, is for with 700 RPM. Very low speed. And we want this speed because we want to recover stem cells. But if you see on the panel, we have IPRF and IPRF-N. Why two IPRF? What is the reason to have two kinds of protocols? You know, my friends, that in this world, we have two kinds of humans. We have the men, and we have the women. But what do we know? We know that the women, they live longer. At least 10 years more than men. Why? In France, we have a term. We say the women, they kill the husband. And this is why they die before. It's a French story, my friend. It's a French story. But what is the the reason. The reason is that the ladies, the women, they have a better blood than the men. They have a lighter blood. They have around 10% less red cells. And this is why the women, they do not too much brain attack. Why the ladies, they do not too much heart attack? Because they have a very good blood quality. And this is why they live longer. But if we have two kinds of humans with two different bloods, we need to make two different protocols. PRF is for women, and PRF-M is for men. You understand that we need to adapt the protocols to the biology. So taking pictures. So today, what is the goal? The goal is to produce a product 700 RPM with a very high concentration of stem cells. Stem cells will help us to make regeneration. Okay, and we have the PRF Plus tubes are for medical use. When you use a low temperature, you will get more glucose. Pump pack improve the quality of the product. There is a reason to change the rotor. Because since few years, we are looking about some publications saying that if you make the tube horizontal, you can get 10-fold increase in platelets. Can you imagine? You change the angulation and you increase 10 times? Who can believe? Only idiots. Only idiots can believe that just changing the angulation will give you 10 times more cells. And when you see a publication, even if this publication is very interesting, we need to get the evidence. What does it mean? That a lot of researchers are publishing that, yes, it's true. But today, what is the feedback from the science? There is no difference. It means that it was a fake publication. There is no interest to change the angulation of the tubes. So, what is the action in the clinic? We say PRF is first a tissue matrix because of fibrin. And then, when you place the fibrin, you will get a new tissue. This is the main function of the PRF. What are the properties? First is to improve the angiogenesis. When you place PRF on the wound, you see the vessels. 5 minutes? Déjà? There is no break, no lunch. Only science today. Non, on peut s'arrêter tant que tu veux. You understand? But you see the vessels on the skin, but not in the gut. Just to tell you, this is the function of you, is to give you more and more vessels. PRF reduce the inflammation. PRF will reduce the pain, because if you reduce the pain, you reduce. If you reduce the inflammation, you reduce the pain. But the fibrin has another function, is to stop the bacteria. And this is why we use today fibrin in open wound. We leave the fibrin exposed because the fibrin is not infected. Simple. Okay? Then we can see the indication. In soft tissue, PRF has undeniable action on angiogenesis. Okay? And then when we use the PRF, when we do a coronal advance flap, then we can see that it improves. But we can see even without. Let's go to analyze the randomized study in comparison between PRF and connective tissue. And what is the conclusion? There is no difference. Another study comparing PRF and connective tissue said there is no difference. But can we believe? No. Why? Because these publications are showing coverage, not sickness. They are not talking on sickness. They just talk on coverage. Then, if we want to improve the sickness, the quantity of keratinized tissue, we should make a different surgical approach. Look at this case. We have two missing laterals with sets of tissue. How to increase the thickness? We can put PRF, but if you want to increase the thickness, you can leave the site open. And then, between the two edges, keratinized tissue will grow. And then it's easy to achieve a very good thickness. You understand that if we want to just to put PRF, it will not give you the whole thickness. If you want, you need to leave a bit open. We can use also the technique in a tunnel, because today we have a very good technique which is named the Vista. We do a tunnel, full flap, not split, full flap, elevation, and then we put PRF inside. You see, we do a tunnel with a vertical incision here, and then we place the PRF inside. And then we can increase the thickness, we can increase the coverage. You see, vertical incision was done here, and then we have the coverage and we have the thickness. We can do a full maxilla. The full maxilla, we make vertical incision over the mucogingival line, and then we put PRF inside. And look how we can cover and increase the thickness. Full maxilla, vertical incision, and look at the final outcome. Mandible the same. Okay?
Oui, moi ça fait, mais on va peut-être poser des questions.
D'accord. And this is the outcome. We can also use the fibrin into the palatal side in order to reduce the pain and to increase the speed of the healing. Yes, PRF is an alternative to connective tissue graft, but in certain cases, not all the time, of course. We will not do any miracle. What does it mean? If your patient has not keratinized tissue before, you will not change the biotype. You cannot change the biotype with PRF. You can just increase the amount of tissue, but the same tissue. We can use also the PRF in periodontology. Today, The modern approach, the modern treatment is not to make a flap, is to use a laser, an ergonomic laser, to remove the infection and to fill the site with fire. We don't need to make a flap, we don't need to make a whole ground when we want to treat the period defect. Okay, look how we introduce the PRF inside the period defect. We don't need to suture. Good. And we can see the outcome. Sorry. You see the difference? Look at the quality of the soft tissue. Look at the quality of the thickness just with PRF and laser. There are some cases from my daughter. She's dentist and she's using the laser in period defect. And we can see how we can improve the amount of bone without flap, without bone growth, just by PRF. Okay, now we can start for questions.
Ok, thì trước khi mình nghĩ giải lao thì cá nhân mình nghĩ là có rất nhiều bác sĩ của đoàn nghiệp như là bác sĩ Mẹo, thì Mẹo ở đây có nhiều cái câu hỏi có thể về nhảy chuột, rất nhiều cái đề tài đối với mình rất là quan trọng và nó có nhân tài thì rất là có thể đơn giản hóa những cái phương pháp điều trị. Có nhiều cái câu hỏi cá nhân về cái địa phương thì bây giờ anh Thủy anh hỏi trực tiếp bằng tiếng Việt sau lên anh dịch cho thầy Sukun bằng tiếng Pháp hay là tiếng Anh của bạn thì mọi người dễ hiểu. Ok, donc je vais te poser une question puis je vais laisser la parole aux autres participants. Cái câu hỏi đầu tiên đó là về cái sự sử dụng của cái APRF thì cái lượng số khi mình xài làm muốn sự lạnh thương tốt đó, thì mình biết là cái thời gian mà nó cái APRF nó tiêu thì là cỡ từ 3-7 ngày trung bình, thông thường 3-4 ngày sau mình thấy là ghép cái APRF bắt đầu tiêu rồi thì cái lượng số mình càng nhiều đó nó có tăng lên cái thời gian của sự tiêu hóa của cái PRF hay không? Ok rồi. Nhưng mà mấy người voilà, donc la première question que je te pose sur l'utilisation du APRF, c'est la quantité. En fait, tu conseilles d'en mettre beaucoup. Parce que si tu mets quelques membranes, ce que je constate, notre expérience personnelle, c'est que le temps de disparition disparaît assez vite. Alors, est-ce que le fait d'augmenter la quantité des membranes augmente ce temps-là et te permet d'avoir plus de temps de cicatrisation ou pas du tout?
PRF is a matrix. And you understand that if you increase the amount of matrix, you can increase the amount of tissue that you want to produce. And I will show you, for example, for extraction, that we put a lot. But the concept is very simple. As much as you can. Always try to put more and more. Because you will get more matrix. You will get more tissue. And if you don't put enough, you will get just a little bit. Other question?
Voilà, đúng là cái câu hỏi thứ hai đó là về cái sử dụng của cái sự lạnh, cái lạnh là những cái cải tiến trong khi dịch đó, thì mình có những cái báo cáo thì lần đầu tiên mình nghe một cách trực tiếp thầy nói về cái sử dụng của cái tốc độ nhiệt độ lạnh như sau đó nhiều khi mình cái tiếng Việt mình không có chuyện mấy thì khi mình xài cái sticky ball đó là mình để vô thì nói là đừng có ép liền lập tức thì khi mình lấy trích ra từ cái phương pháp mình để vô mình làm cái sticky ball đó thì mình phải chờ bao nhiêu thời gian 5 phút 10 phút trước khi mình ép hay là trước khi đó thầy ép liền thì thầy nói là việc mình chờ đấy nó cái ảnh hưởng của sự lạnh nó làm cho nó tạo những cái kiểu một cái tế bào nó tốt hơn thì họ còn bao nhiêu thời gian là phải chờ. Donc là quand tu fais stickable, quand tu presses là, tu dis que maintenant avec le compact il vaut mieux attendre un petit peu
Oui.
avant de presser. Combien de temps? Tu l'as pas
5-10
précisé.
minutes. C'est ce que j'ai dit, 5-10 minutes.
Non, tu l'as pas dit. Theo oublié de dire. Ok, thì thầy anh hỏi thì thầy nói là mình hỏi thì thầy nói là mình phải chờ mình làm cái stickable phải chờ từ 5 đến 10 phút thì mình mới ép xuống thì nó tốt. Mình tại cái nhiệt độ làm
C'est pas pour le sticky board, c'est le pop pack. C'est le pop
Oui,
pack.
le pop pack, oui.
Voilà. C'est bon?
C'est bon. Em có hỏi gì không
Question?
về cái
Có câu hỏi là trong cái GVA, trong cái phẫu thuật mà GVA trong cái implant á, thường mình tăng xương chiều ngang chiều đứng á, thì có cái xu hướng là dùng BMP2, tức là cái sản phẩm tạo để đặt một cái
Anh xin lỗi, em thử em dịch cho tại vì nhiều cái từ của thầy Mẹo anh không có hiểu tiếng Việt á.
Dạ, tức là trong cái kỹ thuật mà GVA trong cái implant á, thì thường mình đặt cái xương mà kết hợp với tỷ lệ 1:1 giữa cái xương thượng thân với cái xương vật liệu thay thế, thì sau đó mình đặt một cái lớp BMP2 á, để cho nó tăng cái tạo cái xương mới. Thì đối với cái quy trình mà cái PRF mình đây á, thì nó cũng có phóng thích nhiều cái protector. Như vậy á, mình có thay thế được cái BMP2 trong cái trường hợp này trong cái chuyên ngành.
Okay. No. Okay, go to translate.
Okay, I will translate.
I'm sorry, my friend. Nobody today, nobody in the world is still using PRF. Nobody.
Ngày nay không có còn ai trên thế giới sử dụng PRP nữa.
Why?
Tại sao?
Because all the people who are using the BMP2 were meeting over treatment.
Tại vì thường các
The problem of the BMP2 is when you put the BMP, you have a very nice simulation, but you have a wave, like a tsunami. You know what is a tsunami? It starts and then it takes a long time. BMP2 using is creating a tsunami of pole formation. And then after, we are getting more pole. This is not biology. What does it mean? It means the signal of the BMP2 is too much. We must use very, very, very low dose. But finally, we don't need BMP2. And today, all over the world, all the teams, they stop it. I mean, serious teams.
Thì theo thầy á, thì bây giờ trên thế giới người ta không có sử dụng PMP2 nữa là tại vì cái cơ chế của PMP2 nó giống như là gọi là sóng thần vậy đó. Tức là nó sẽ tạo nên một cái lượng thông điệp rất là mạnh, lượng signal rất là mạnh, và nó sẽ tạo nên rất một lượng lớn số lượng xương mà mình thậm chí không có cần thiết. Còn trong khi cái mặt sinh học thì nó phải cần.
I will show later much more interesting protocols than BMP. But no money. Why? What I promote is to improve the technique with no money.
Thì rõ là cái PRP2 đó là nó tạo cái điều kiện khi mà nó kích thích rất là mạnh, kích thích nhiều cái tsunami này. Mà cái vấn đề của thầy nói là nếu mà mình kích thích mà mình đã tạo lại cái xương rồi đó, thì sau cái thời gian nó lành thương mà mình cắm trên rồi mà nó càng xương nữa. Và cái giải pháp của hồi trước nếu mình làm như vậy đó thì em là có thể trong đó nó sản xuất xương nữa và nó làm những cái mọc xương như mấy cái mọc xương thêm cái gì đó, thì cái đó là một cái mà mình nên tránh đi. Hay là mình phải giảm lại, mình giảm cái tỷ lệ giữa cái xa xài và cái tỷ lệ em giảm lại, em biết sao được, rất là khó. Tại giữa cá nhân của mỗi bệnh nhân là cái vấn đề bỏ ý hơn.
Okay, allez, break.
Rồi mình nghĩ gì đâu.